clinical acumen. So can I call the next speaker, that is on genetic testing, Is It Worth the Money, by Dr. Nageshwara Rao from Hyderabad.
Thank you very much, Dr. Amitabh. It is indeed my great pleasure to be part of this program. I thank the organizers. I feel this is very, very important to talk pertaining to the present context. The genetic testing, is it worth the money? I would like to thank my colleagues, Dr. Bhargavi. She is now the in charge of the cardiac genetic program in our hospital. Earlier, Dr. Sai Leela, now she is at Chennai, started our program in 2015 and then pursued till 2017. We had COVID for 1.5 years where we did not do much work, but again, we restarted. If you look at the spectrum of genetic disorders in the society, there are so many major chromosomal abnormalities like Down syndrome and multifactorial single gene deletions like Daijardi syndrome and multiple gene disorders which are all present in the society, which constitutes in the bell curve lesser than 5th percentile. When you consider the first degree relatives, which is really pertinent to our society, especially in Andhra Pradesh and Telangana, where consanguinity is very commonly seen, the affected individuals are going to be much more significant. So why should we do the genetic testing? Genetic information allows you for improved diagnosis, prognostication, genotype specific therapy, family testing, and prenatal testing and application of the implantable devices. I would actually take very seriously if there is a family history of SCD to have the device or medical management, lifestyle modification, exercise management, lipid and blood pressure management is coming now more commonly. Examples like hypertrophic cardiomyopathy can be likely pathological in gene who is asymptomatic. He may develop a problem later on. Similarly, type 3 long QTc syndrome may be benefited by mexiletine medication. So what is genetic testing? A major chromosomal abnormalities like karyotyping can be done. Fish microarray can detect the Williams syndrome, Daijardi syndrome. A single gene, what we are talking is the disease-targeted gene panels, whole exome sequencing, whole genome sequencing. This is the methods which they do are going to be more and more important in the future. So in the congenital heart diseases, it is straightforward when you see the syndromic baby to advise either karyotyping or fish or microarray. If it is running in the family or you are suspecting anything very abnormally in the family, then only we use this genetic testing. Otherwise, by and large, we don't advise for all congenital heart disease to go for the genetic testing, because every human being can have one or other form of genetic abnormality. If you go on doing the whole exon or whole genome sequencing, it is going to cause more and more confusion. So what is the scope? So you should form a cardiovascular genetic program in your hospital, in your institute, and you should define who are the stakeholders, patients, families, and you should talk to the hospital, healthcare system, and probably it is a good idea to inform to the government, and you always should think about the legal aspects. You have to form the team. I again thank my previous colleague, Sai Leela. She formed a team which constitutes a cardiologist, genetic counselor, and the person who is doing the testing. We were doing a medgenome and a clinical genetician, electrophysiologist. We all involved now. It's going to be, we are now enhancing the team with the cardiovascular nurse and also a social worker with the help of Dr. Bhargavi. She is now in charge of our program. A clinical cardiovascular genetic program should have comprehensive cardiac assessment and genetic assessment. A comprehensive cardiac assessment constitutes a family history, physical examination, imaging, and she should publish a lot of research and identify the variants of unknown significance for future reference. Similarly, a genetic assessment should have detailed understanding of about heritable cardiovascular disease, pattern of inheritance, genetic variation, and post-test counseling is going to be major important. This is the family. One patient came with catecholaminergic polymorphic VT. There was a sibling death. Upon asking the history, there were 5 deaths in the family, and which became very strong positive in that category. So the challenges are interpretation of the genetic results. What is variant of uncertain significant? Whether are we offering a pre-test and post-test counseling are going to be challenging. That's where you need to classify which is the pathogenic, which is likely pathogenic, which is variant of uncertain, or likely benign or benign, because you can't threaten the family with the genetic testing. There are two important issues. Is it genetic testing and genetic counseling? Genetic testing alone will not give any information, will not solve the problem. You should have pre-test and post-test counseling. So genetic counseling aids people to understand and adopt medical, psychological. Actually, in West, they actually recruit a psychologist to counsel these families. So genetic counseling is very important in the family, and it should be patient-centered, and we should always take a consent in a grown-up people. Otherwise, it is going to cause a serious problem. Whenever there is a suspected clinical diagnosis with a family history, disease-specific panel is important, like a HCM and DCM. Whenever you suspect a clinical diagnosis and a family history of a different cardiomyopathy, then cardiomyopathy panel. Whenever there is a clinical diagnosis and a family history with a different and arrhythmias, then comprehensive panel. Otherwise, if you have a just a suspicion, just one family member, either whole exome sequencing or whole genome sequencing is going to be useful. In that, it is going to be challenging to assess the genetic testing. So insurance is not available for the testing. Ethical, sometimes it's going to be very difficult in community, religion, and caste-based issues will come. And social sharing among family members may not be good idea sometimes. And sometimes life insurance, if you label as a genetic disorder, they may not get life insurance and disability insurance. These are all going to be legal considerations. At this point of time, whole genome sequencing is 30,000, clinical sequencing 24, and single variant they are charging around 5,000. If you're talking to them, it may come down little bit more. But American Genetics Association, Medical Association showed that there is some kind of disagreements in 45% of the gene analysis, and they don't agree with the unknown variation at this point of time. Now, more and more people are growing directly to consumer genetics. These are all various, so close to 40 genes which are identified. This is the only thing which is actually accepted by American College. So when you think about that, cardiomyopathy, channelopathy, vasculopathy, and miscellaneous will be there. So this is our data of 40, close to 40 cardiomyopathies we screened, of which we had 14 patients which became positive, of which definitive pathological positive were 5 cases, and variant of unknown significant, we are closely following them, and which are close to around 9 cases. So this is the hypertrophic cardiomyopathy, a patient with a family history in the father had same problem, and which was strongly positive for the genetic. So we screen all family members with this kind of disorders. So you can see other variants like a non-compaction and Wolff's anomaly. We found a novel mutation in one of the case, which again needs a lot of counseling. When you have cardiomyopathy, you have to take 3 generations history, pre-testing, counseling, and panel. What you are going to do, then analyze the pathological variant, keep the variant of uncertain, and benign you can exclude and counsel them nicely. Channelopathies, we have 12 cases of long QTC, of which 7 are positive. In that, family history is quite present in sibling history, sibling death, and you can see the Sagrans sequencing, single gene positive in 1. This is the index case of one of the long QTC, and the father is positive here, very long. He was asymptomatic. This is another very long QTC here, genotype positive, and initially, then it became normalized. This is another vascular disorder, iotopathy, FBN positive. It is like a Marfan's variant. All 3 family members in the family is positive are having a dilated aorta +4, and they have length dislocation. Another interesting case with arterial Tochiasti syndrome with the cutis laxica. Emilian gene is positive here. You can see the aorta, which is very, very significantly damaged. Dr. Mahesh from Cochin, he has got largest series in this in a particular community, and he published his data. Probably we can discuss that later on. This is another 10 months old baby presented with severe LV dysfunction. We found arteries are calcified, and then we actually took the genetic cardiac panel, and which became positive here, exon 12 positive, and which is autosomal recessive, but unfortunately it is uncertain significant. Child started on bisphosphonates, and now ventricular function improved in this case. Another interesting case of 6 years old child came with AST, and we took the child in the lab and showed PA pressures are high here, and we did not do the device closure. We assessed her in the hospital. We found that there was a sleep apnea, and the saturation was significantly falling in her situation, and after oxygen she improved very well. So we were wondering, and then we thought we will do some of the tests in this. After seeing, she became positive for surprisingly to the myasthenia gravis like syndrome. So it's a congenital myasthenia, and she responded very well for fluoxetine and acetylcholine receptor blocker, and she is ready for the procedure now. Another case with familial pulmonary hypertension treated. So post-test counseling we offer to them and educate them, and we are going to occupational issues, social issues, and therapeutic modality we offer. This is our first publication in the current issue of APC. Myself, Dr. Shailila, and other genetic counselor, we published this, our initial data from our genetic lab, our genetic clinic. Thank you very much for your kind attention. This is our brochure of our genetic clinic here, and we have once in a month clinic. We regularly do that. Thank you very much for your kind attention.
Thank you, Dr. Rao.